We're going to be discussing mapping and alcohol ablation of the vein of Marshall, mechanistic basis, technique, and clinical trial data. The vein of Marshall is an atrial vein of the coronary sinus that lies in the epicardial aspect of the left atrial ridge, and it contains abundant parasympathetic and sympathetic innervation that has been linked to a pro-arrhythmogenic state of the underlying atrial myocardium by shortening action potential duration and other modulations exerted by the intrinsic autonomic system. Back in the 70s, Ben Sherlock showed that the vein of Marshall could be a site of atrial fibrillation triggers, and this was clinically proven later on by Chong Huang in the year 2000 when he cannulated the vein of Marshall using a Cardima catheter and showed initiation of atrial fibrillation arising from ectopic beats in the vein of Marshall that preceded even ectopic beats from the pulmonary veins. With these ideas in mind, in 2007, we set out to test the idea that we could cannulate the vein of Marshall via an endovascular approach and insert a balloon through which we could deliver ethanol to achieve a local ablation that could help us target these arrhythmogenic substrates. And indeed, we published a series of animal experiments in 2009 where we had done cannulation of the vein of Marshall in canines and performed a 3D map of the left atrium before and after ethanol infusion. And we showed that we could achieve a small area of scar in the neighborhood of the vein of Marshall, going from the mitral annulus towards the left inferior pulmonary vein. And perhaps more interestingly, we showed that this alcohol ablation could eliminate vagally induced shortening of the action potential duration. This was tested in dogs by stimulating the vagus nerve in the neck. When you do that, you create a shortening of the action potential duration, about 30%. Where after giving alcohol in the vein of Marshall, we blunted that response, specifically in the neighborhood of the vein of Marshall, thus proving this idea that we could selectively denervate the left atrium by giving ethanol infusion in the vein of Marshall. When examining the tissues after alcohol injection, we could see some pale tissue around the vein of Marshall and continuing on the ligament of Marshall. Let me remind you that the ligament of Marshall is the atretic portion of the vein of Marshall that would have been normally the left superior vena cava. By the normal embryogenesis, it shrinks and becomes atretic, and it contains just a twig of innervation. With those animal results in mind, we went on to take this to the clinic and do it in humans. And after a lot of paperwork, we were able to get approval for first human case. It turns out that in humans, the vein of Marshall is easier to cannulate than in dogs, it's bigger. And when we give alcohol in the vein of Marshall, we create a large area of ablation that can help us deliver ablation in a large chunk of tissue from the mitral annulus, in the coronary sinus side, towards the left inferior pulmonary vein. We then tested a large series of patients that had failed a previous ablation to see if the vein of Marshall could be the reason for these ablation failures. And the first question we asked ourselves was whether the vein of Marshall could still have electrical activity even after extensive ablations. And in a series of 54 patients that had been previously ablated, some of them with extensive ablation, you can see this voltage map of the endocardial left atrium showing all red, meaning no voltage. Even mapping with a lasso in the lateral wall showed no voltage, and yet in 54 out of 54 patients that we were able to get microcatheter in the vein of Marshall, we did show that the vein of Marshall had intact electrical activity, supporting the idea that normal ablation does not really target the vein of Marshall electrical activity. In a small subset of patients that had reconnection of the left inferior pulmonary vein, we tested this idea that had been mentioned by certain key opinion leaders that there could be vein of Marshall connections from the pulmonary veins into the left atrium that could bypass previous ablation lesions. And we tested that hypothesis by pacing the vein of Marshall and seeing whether that pace stimulus in the vein of Marshall could advance the pulmonary vein potential. And in a rare proportion of patients, 5 out of 32 patients with reconnected left inferior pulmonary veins, we could see that pacing in the vein of Marshall could advance the PV potential. Compare this to a sinus beat. When we pace the vein of Marshall, the PV potential comes earlier than the far field atrial activation, as you compare that in sinus. Thus proving the idea that in certain patients, there could be connections from vein of Marshall into the pulmonary veins that could make the substrate for recurrent atrial fibrillation. We could not really make a prediction based on angiographic or fluoroscopic appearance, but suffice it to say that you can see here in this case the Cardima catheter, which is now extinct, unfortunately. This Cardima catheter was advancing to the vein of Marshall, and it was quite close to the lasso, which was inserted in the left inferior pulmonary vein. This is work that we did in 2010 and published in 2012, but nevertheless still valid. Now, we don't have this catheter anymore, but we have a similar one. What we also saw during these studies of recurrent AFibs and failed ablations was that when we cannulate the vein of Marshall and deliver ethanol, we could achieve disconnection or redisconnection of the pulmonary veins. Depending on the vein anatomy, we could disconnect the left superior pulmonary vein, as shown here, and also the left inferior, depending on branching patterns of the pulmonary veins. In only 2 out of 54 patients could we really demonstrate a trigger of atrial tachycardia or fibrillation coming from the vein of Marshall. This is one such example where we had a quadripolar catheter in the vein of Marshall. And that was the earliest activation arising from vein of Marshall proximal here, and that was treated with alcohol, leading to tachycardia termination and disconnection of the pulmonary vein. Similar findings were later reproduced by Keida and others from Tokyo, where he showed in a patient with recurrent isolated ectopy triggering atrial fibrillation after pulmonary vein isolation that the patient had unequivocally a source from the vein of Marshall. This patient had simultaneous lasso mapping of the left superior and left inferior pulmonary vein, as well as the vein of Marshall. They showed that the triggers came from the vein of Marshall, and that during infusion of ethanol, the ectopy completely ceased. Similar studies were conducted by Aman Chug in Michigan, where in their hands, they showed that a PV connection mediated by the ligament of Marshall was observed in 32 patients of patients coming back after ablation. Our experience was only 5%, so it's a lot less, but they did not use selective multi-electrode mapping of the vein of Marshall, so their assessment was much more inferential than ours. They did find 23% of patients having a vein of Marshall, ligament of Marshall mediated tachycardia. And they did find perimitral flutter that was successfully ablated with ethanol in 94% of the patients. This was published in 2018. We had published our previous experience on vein of Marshall alcohol for perimitral flutter 6 years earlier. And we had shown that with the Cardima catheter in the vein of Marshall, number one, we proved by entrainment maneuvers that the vein of Marshall is in the reentrant circuit of perimitral flutter by entrainment maneuvers, as shown here. And we also showed that in 77 out of 77 patients studied, when we gave alcohol plus ablation, we achieved perimitral block, bidirectional perimitral block in all of the cases. In most patients, some radiofrequency was required, and that's expected. You have to keep in mind that when you give alcohol in the vein of Marshall, you create a lesion that is in the mitral isthmus, but it's not a complete mitral isthmus line because the CS itself, and there's more annular aspects of the mitral isthmus that do not get alcohol. In our experience here, either de novo or repeat ablations, a median of 2 minutes of radiofrequency was required to achieve bidirectional perimitral block. It is a minor amount of radiofrequency, but in all cases, we achieved perimitral block. There were cases where the patients had been ablated before, patients came back with perimitral flutter. We could try to map the circuit, and it appeared either a focal arrhythmia arising from the mouth of the appendage and rotating counterclockwise along the mitral annulus, or perhaps a reentrant circuit that we were missing the last third of the tachycardia circuit that was missing in the scarred mitral isthmus. In situations like this, we were able to complete the map by getting signals from the vein of Marshall, now no longer with the Gardner catheter, but with an angioplasty wire configured as a unipolar electrode. If you annotated the activation times based on the angioplasty wire at different levels of the vein of Marshall, we could complete the circuit, and with ethanol infusion, the tachycardia will stop. Similar experiences have been shown by the Japanese, mapping and ablating vein of Marshall mediated recurrent perimitral flutters. We later on studied the presence of cardiac innervation in human atrial fibrillation by doing high frequency stimulation in the vein of Marshall. This was a complex protocol, but we did it in two different settings. One was a burst or synchronized short burst of high frequency stimulation, synchronized to the P wave in a way that we will not capture the atrium. So this was meant to stimulate innervation, but not stimulate myocardium. So as you can see here, in half of the patients we studied, these were patients that some of them had previous ablations. By doing high frequency stimulation synchronized to the P wave, we could trigger atrial fibrillation that, number one, did not depend on myocardial capture. You can see this is a sinus beat after the synchronized high frequency stimulation. And then AFib starts, and the very first beat arises from the very vein of Marshall. Thus proving that, number one, we can stimulate innervation that can trigger AFib, and that the onset of AFib initiates in the vein of Marshall. When we gave alcohol, we repeated this procedure, and we could not trigger anything, thus suggesting the idea that we could de-innervate that area. It was far simpler to test this concept by doing a long burst of high-frequency stimulation, not synchronized to the P wave. The price you pay here is that you capture the myocardium, so you're going to induce atrial fibrillation. But the interesting part of it is that during these long bursts of high-frequency stimulation in the vein of Marshall, we could trigger asystole. This mechanistically is fascinating to me, that when you pace in the lateral left atrium, where the vein of Marshall is, somehow through interneurons, you connect with the ganglion that controls the AV node and induce a parasympathetic response in the AV node by causing AV block. However, transiently, but up to almost 6 seconds in these cases. The interesting thing is that after giving alcohol in patients like this, we would repeat the high-frequency stimulation, and we would no longer trigger asystole or atrial fibrillation. Again, we have then proved that the vein of Marshall contains innervation, and that the vein of Marshall is a vascular route to target the left atrial innervation in humans. We've done more studies now with the EP-STAR from Baylis. It's another miniaturized microelectrode catheter that can be inserted in the vein of Marshall, and they can prove in certain cases interesting situations, like this patient that had undergone previous mitral isthmus ablation came in with perimitral flutter. Pacing the appendage would lead to an activation coming from appendage along the lateral wall towards the CS, but then when you map the CS activation, so that when you map the vein of Marshall activation, it activates from proximal to distal, thus supporting the idea that there could be endoepicardial dissociation in the mitral isthmus when you do an incomplete ablation. Also, we can see in certain cases very disorganized signals in the vein of Marshall prior to ethanol delivery that they get eliminated with ethanol. When you give alcohol in the vein of Marshall, you create a scar that can be mapped not only with 3D mapping as an area of low voltage that goes from the mitral isthmus, from the mitral annulus to the left inferior pulmonary vein. You can see it on intracardiac echo as the left atrial ridge gets very echogenic with ethanol. And actually, if you do MRIs pre and post, you can actually see an area of delayed enhancement along the left atrial ridge. It takes about 45 minutes to do and about 10 minutes of fluoro. That's the original experience, and that's been kind of confirmed. Obviously, when you get better, when you get more experience, you get better, you get quicker. We did not have any complications associated with this procedure, at least attributable directly to this procedure. With this data in mind, we set up to design a clinical trial to really look at the outcome differences in ablation patients. So we decided to design two clinical trials called Venus and Mars, respectively. Venus was meant to be a randomized clinical trial for patients that had persistent atrial fibrillation and that were undergoing their first ablation. And Mars was for patients that had a previous ablation failure and then would be randomized to conventional ablation alone or combined with Veno Marshall. The primary endpoint was freedom from atrial fibrillation or flutter. We measured this with 1 month event monitors. It's the same thing. Inclusion criteria included patients between 18 and 85 years of age, symptomatic persistent atrial fibrillation, refractory to at least one drug. We excluded patients in Venus with previous ablation attempts, patients with massive left atria exceeding 65 millimeters diameter or 200 cc's of volume, and we excluded patients with low ejection fractions. The patients and the EKG core lab were blinded to the randomization outcome, and this was funded by the NIH. The primary endpoint was freedom from atrial fibrillation or tachycardia of greater than 30-second duration after a single procedure without the use of antiarrhythmic medications and occurring after a 3-month blanking period. The rhythm assessment was done with a continuous 1-month monitoring at 6 and 12 months. We had secondary endpoints, freedom from AT or AF after more than one procedure or on drugs, atrial fibrillation burden on the monitor, and procedural parameters, perimitral block, and recurrence as atrial fibrillation or atrial tachycardia. This is the trial design. We plan to enroll 156 patients in the catheter ablation group and 180 patients in the catheter ablation plus Veno Marshall ethanol, predicting that we would fail to cannulate the Veno Marshall in 15% of the patients. And the idea was that we would over-enroll in the catheter ablation Veno Marshall group so that we could compare an equal number of patients treated with alcohol in the Veno Marshall group compared to the control group. After the 3-month blanking period, we would monitor the patients with visits, as well as 1-month monitor at 6 months and at 12 months. Patients could fail either if they showed up with clinical recurrences of atrial fibrillation or tachycardia, or if they had more than 30 seconds of atrial fibrillation or tachycardia on the monitor. We enrolled over 5 years. It was quite an arduous procedure to enroll patients, but we completed enrollment, albeit 1 year later than expected. But the trial was completed successfully. And we enrolled a total of 343 patients in 11 centers, 185 randomized to Veno Marshall plus ablation, 158 randomized to ablation. In 30 patients, the Veno Marshall was not doable. And that's why we had to do an as randomized analysis, the patient that were in that randomization group, and then as treated patients, taking patients that had a successful Veno Marshall alcohol. In 27 patients, 13 in the Veno Marshall group and 14 in the controls, we did not have complete follow-up data because the patients did not complete the 1-month monitoring follow-up. This trial will be published in October 27 in JAMA. These are the results, either as randomized or as treated analysis. The Veno Marshall led to a reduction in recurrences. Looking at atrial fibrillation or tachycardia occurrence after single procedure in as randomized analysis, and the hazard ratio was 0.73. Confidence interval was 0.999, but JAMA only lets you round to 2 decimals, so it shows up at 1. The p-value was 0.049, but JAMA only allows you to round it to 2 decimals. If you look at the as-treated analysis, hazard ratio was 0.67, significant reduction of recurrences in the Veno Marshall group, confidence interval below 1, and a p-value of 0.02. So the primary endpoint, the freedom from AFib, was achieved in 49% of the patients in the intention to treat group, 51% of the patients in the per treatment group, and in 38% of the patients in the catheter ablation group. So you could say we only achieved single procedure success in 38% of the patients with the control group. And that is because of many different reasons, but in part because we had 55% of the patient population was patients with long-standing persistent atrial fibrillation. If you look at the primary endpoint components, atrial fibrillation or atrial tachycardia recurrence, excluding death or missing data, ablation success, so the recurrence was 51% in the catheter ablation group. It was 41% in the intention to treat VOM group, and 40% in the per-treatment group. There was no difference in terms of the recurrence being clinical or detected on the monitors. Secondary endpoints, freedom from AFib after repeat procedures, 53% of the catheter ablation group versus 62% in the intention to treat VOM and 65% in the catheter ablation VOM per treatment group. The number of patients that had zero AFib on monitoring was 67% in the catheter ablation group versus 76% in the VOM intention to treat and 78% in the VOM as treated group. There were a reduction in the number of repeat procedures required. 25% of the patients required repeat procedures in the control group versus 17% in the VOM group. This is the distribution of AFib burdens. It's simpler to see in the left bar graph that more patients in the VOM group had zero AFib than higher percentages compared to the control group. There were adverse events. The most common adverse event that was perhaps slightly higher numerically in the VOM group was fluid overload. Other adverse events were very similar. In conclusion, the VOM contains innervation that can be profibrillatory, can harbor triggers of atrial fibrillation and PV reconnections, and it sits on the epicardial aspect of the mitral isthmus. VOM ethanol combined with pulmonary vein isolation can improve single procedure success of catheter ablation of persistent atrial fibrillation, reducing atrial fibrillation and atrial tachycardia recurrence, reducing burden of atrial fibrillation, and reducing the need for repeat procedures. Thank you very much.